So, imagine you are living in London, right? But it's the 1850s.
Oh boy. So lots of smog.
Yeah, exactly. Terrible air. And you have this awful respiratory condition. You're wheezing, your chest feels like it's, I don't know, wrapped in iron bands.
Sounds completely miserable.
It is. You were just desperately struggling to catch your breath. So you finally make it to the doctor.
Okay.
And his actual literal prescription is for you to walk down to the apothecary, buy a pack of something called asthma cigarettes, and just smoke them.
Which is, I mean, telling someone who can't breathe to go smoke a cigarette is wild enough.
Right. But it gets crazier. Because the most shocking part of this is what those cigarettes were actually made of.
Oh, yeah.
They were made from plants with names like deadly nightshade and jimsonweed.
Yeah, which is just, wow.
You are literally inhaling the smoke of known, lethal, poisonous plants just to breathe easier.
It sounds completely absurd, like almost barbaric to our modern ears.
Oh,
Because we're talking about Atropa belladonna here.
That's a famous poison, right?
Oh, absolutely. A plant famously used as a poison throughout history. I mean, it's capable of causing terrifying hallucinations, paralysis, and, death.
But the wild thing we found in the sources is that those Victorian doctors were actually onto something profound.
They really were, even if they didn't, fully understand the molecular science behind it at the time.
So that brings us to the mission of today's deep dive. We are looking across this massive stack of sources today. Historical medical journals, decades of pharmacology textbooks, raw data from massive clinical trials.
A lot of heavy reading for this one.
Yeah, quite a bit. But our goal is to understand how modern medicine essentially harnessed a deadly poison.
Right. We're looking at a class of drugs known as anticholinergic inhalers.
Specifically for those taking notes, molecules like ipratropium and tiotropium.
And we really want to understand how they pull off this dual medical magic trick of basically drying and widening your airways.
Which is an absolute game changer for millions of people, especially those suffering from chronic obstructive pulmonary disease or, COPD.
Yeah. Getting from burning deadly nightshade in a Victorian parlor to carrying this safe, highly calibrated pocket-sized inhaler, it requires some of the most elegant molecular engineering in medical history.
Really is a brilliant journey.
It is. But our sources highlight this massive lingering issue that we actually have to confront first.
Right, the linguistic mess.
Exactly. It's a linguistic mess that still causes real harm today.
I noticed that right away in the pharmacology texts, like the very name we use for these drugs, anticholinergic, is technically super sloppy.
Extremely sloppy.
And it creates a lot of unnecessary panic, because right off the bat, a precise pharmacologist wouldn't even use that word.
No, they wouldn't, because the neurotransmitter we are dealing with here is acetylcholine, right?
Which is basically a chemical messenger.
Exactly. And acetylcholine acts on two totally different families of receptors in your body.
Okay, so break those down for us.
Well, first there are nicotinic receptors, which handle things like the voluntary movement of your skeletal muscles.
Like me moving my arm right now.
Yes. And then there are muscarinic receptors, which control involuntary functions.
Stuff we don't think about.
Right. They're found on smooth muscles, glands, and the heart.
And fun fact from the sources, they're called muscarinic because they're activated by a specific mushroom toxin called muscarine.
Which is a fascinating little piece of botanical history on its own.
Right. So these modern inhalers we're discussing, the ipratropium and tiotropium, they are laser focused.
Incredibly focused.
They only block the muscarinic receptors. They completely ignore the nicotinic ones.
Which means calling them anticholinergic is just far too broad. They really should be called antimuscarinics.
But the older term just kind of stuck around.
Yeah, it's a holdover from the era of plant-based pharmacology. And the real problem is that it lumps these highly targeted, lung-selective inhalers into this much larger, messier family of systemic drugs.
So what else is in that family?
Well, we're talking about older oral antihistamines, certain procyclic antidepressants, and drugs for overactive bladders.
And lumping a targeted lung inhaler into the exact same category as a systemic antidepressant. I mean, that has real-world consequences for patients, doesn't it?
Massive consequences. Because those older systemic drugs, they flood the entire body.
Right.
And they cause significant side effects. We're talking confusion, severe dry mouth, and dangerous fall risks, especially in older adults.
How do hospitals handle that risk?
Well, they use these geriatric anticholinergic burden scales.
Basically a scorecard.
Exactly. Doctors use these scales to tally up a patient's total exposure to these drugs to predict their risk of, cognitive decline or dementia.
But here's where the sloppy linguistics cause a huge problem, right? Because of that old name, those scales sometimes score a localized inhaled drug like tiotropium the exact same way they'd score a heavy, oral, sedating antihistamine.
Which is completely inaccurate clinically.
And that leads directly into one of the biggest misconceptions I found. There's this huge fear that using these COPD inhalers will cause dementia in the elderly.
Right, just like taking too much Benadryl might.
But that is fundamentally misunderstanding how these specific molecules interact with the human body.
Completely, because, well, the structure of the molecule dictates where it can go.
Okay, so to understand why these modern inhalers don't cause that systemic brain fog, we really have to look at the chemistry hack that saved this entire class of drugs.
Yes, let's get into the chemistry.
So going back to those Victorian asthma cigarettes, the active ingredient in those was a plant derivative called atropine.
Right.
And atropine was a total nightmare of a drug to use clinically.
I mean, it opened the airways, sure, which is what they wanted.
But atropine is what chemists call a tertiary amine.
Which, for those of us who aren't organic chemists.
Right. The crucial detail is that it's a small, highly fat-soluble molecule.
And our cell membranes, including the incredibly strict blood-brain barrier, they are composed of phospholipid bilayers.
Essentially layers of fat.
Exactly. So a fat-soluble molecule like atropine faces no resistance whatsoever.
It just glides right through.
Yeah, it easily crosses the blood-brain barrier, it crosses the gut wall, it gets into the bloodstream and just circulates systemically throughout the entire body.
The analogy that came to mind when I was reading this is like atropine is this chaotic guest who shows up to a party at a giant mansion.
I love this analogy.
Right, because you really just want them to stay in the kitchen. The kitchen represents the lungs, right?
Yeah.
You want them there to help you cook.
Sure.
But because all the doors in the mansion are unlocked, they just wander into every single room of the house.
They're everywhere.
Yeah, they're knocking over lamps in the living room. They're sleeping in the master bedroom, just making a total mess.
And medically, that chaotic wandering creates a very specific and honestly terrifying clinical picture.
Yeah, the side effects.
Medical students actually still memorize a folk rhyme to spot atropine poisoning in the ER today.
Oh, I saw this in the sources. How does it go again?
It goes, mad as a hatter, blind as a bat, dry as a bone, red as a beet, hot as a hair.
That sounds absolutely horrific.
It really is.
So you're getting hallucinations, blurred vision, zero saliva production, flushed skin, and this racing fever.
Yeah.
And you're suffering all of that collateral damage just because you wanted to cure a cough.
Exactly. So the side effect burden was completely unacceptable for chronic daily use.
Obviously.
So the question that defined respiratory pharmacology for decades was, how do we keep the airway opening magic of atropine, but physically stop it from crossing the blood-brain barrier?
And the answer finally arrived in the 1960s.
Yes, thanks to scientists at the German pharmaceutical company Boehringer Ingelheim.
They pulled off what I can only describe as a brilliant piece of molecular engineering.
It really was.
They took the atropine molecule, that fat-soluble tertiary amine, and they converted it into a quaternary ammonium compound.
Right.
Which in plain English means they literally bolted a permanent positive charge onto the molecule.
Just strapped it right on.
Right.
And bolting that permanent positive charge onto the structure fundamentally alters the molecule's physical properties.
Because remember, cell membranes are fats.
Right, and water and fat repel each other.
Like oil and vinegar.
Exactly. So by adding that permanent positive electrical charge, the molecule becomes highly hydrophilic, meaning water-soluble.
So it suddenly cannot easily cross those fatty cell membranes anymore.
Not at all. It acts like a magnet hitting the wrong pole. It just bounces right off the blood-brain barrier. It bounces off the gut wall.
So you take this newly charged molecule, you put it in an inhaler, you breathe it deep into your lungs, and it effectively gets trapped there.
Yes, it stays localized in the airway tissue to do its job, and only a tiny, poorly absorbed fraction ever makes it into the general circulation.
Meaning it completely sidesteps the hallucinations, the severe heart racing, all of that nightmare stuff.
All of it. This single structural change birthed the drug ipratropium, brand name Atrovent, which completely revolutionized European respiratory care in the 1970s.
But I do want to push back on one thing here just to be crystal clear for the listener. Because a lot of people assume that since the drug is trapped in the lungs, it has zero systemic side effects.
Mm-hmm.
But the sources are pretty clear that patients still need to be a little cautious, right?
Oh, that's a really vital distinction. That quaternary structure greatly limits the absorption, but it doesn't reduce it to absolute zero.
because of how inhalers work physically?
Exactly. When you use an inhaler, some of the aerosolized drug inevitably hits the back of your throat and gets swallowed.
Right.
And a very small fraction does absorb from the gut. I mean, it's not enough to cause hallucinations, but it can cause mild systemic anticholinergic effects.
Like what?
Well, patients frequently report dry mouth, and more seriously, men with enlarged prostates need to be careful because it can cause urinary retention.
Okay, good to know.
Furthermore, if the mist from the inhaler accidentally sprays directly into a patient's eyes, it can dilate the pupils and dangerously worsen a condition called narrow-angle glaucoma.
Wow, okay. So it's overwhelmingly local, but it's not entirely foolproof.
Right.
Okay, so we've hacked the chemistry to keep the drug primarily in the lungs. Let's talk about the plumbing of the lungs themselves. What exactly is this drug doing when it gets down into the airways?
Well, to understand the plumbing, we actually have to look at the wiring first.
The nervous system,
Yeah. The major nerve supplying the human lungs is the vagus nerve.
which is part of the rest and digest system, right?
Yes, the parasympathetic nervous system. So in the lungs, the vagus nerve releases our neurotransmitter acetylcholine right next to the airway smooth muscle and the submucosal glands.
And in a healthy person, this is just like normal baseline maintenance, keeping a slight resting tone in the airways so they don't collapse.
Exactly. But in someone with COPD, which includes chronic bronchitis and emphysema, things go completely haywire.
Because COPD is heavily driven by chronic exposure to environmental irritants, right?
Yes. We're usually talking about decades of inhaling cigarette smoke or long-term exposure to severe occupational dust or heavy air pollution.
Over time, those irritants just trigger this exaggerated reflex.
Yeah. The vagus nerve basically goes into a state of panic and overdrive. It begins dumping massive, inappropriate amounts of acetylcholine onto the muscarinic receptors in the airway.
And specifically, it's hitting the M3 subtype of those receptors.
Yes, M3 is the main culprit here. When acetylcholine hits the M3 receptors located on the smooth muscle surrounding the airway, the muscle powerfully contracts.
It just spasms.
Right, which physically narrows the breathing tube.
And it gets worse, right, because of the glands.
Yes. When acetylcholine hits the M3 receptors on the submucosal glands, those glands respond by secreting excessive amounts of mucus.
So if we connect this back to our plumbing analogy, it's an absolute crisis.
Oh, total crisis.
Because it isn't just that the pipe is squeezing shut, which is terrifying enough when you're trying to breathe.
Yeah.
It's that the pipe is squeezing shut while simultaneously actively filling up with thick sludge.
Sludge is the perfect word for it. It's this nasty combination of hypersecreted mucins and trapped inflammatory cells. It blocks the small airways, traps air in the lungs, and makes every single exhalation a massive physical effort.
The patient literally feels like they are slowly suffocating.
But when they inhale that positively charged anticholinergic drug like ipratropium, the drug blocks those M3 receptors.
So the acetylcholine has nowhere to bind.
Exactly. The smooth muscle relaxes, which widens the pipe, and the glands stop hypersecreting, which turns off the sludge faucet.
Drying and widening.
Drying and widening.
And from what I read, because you can't reverse the physical structural destruction of the lung tissue that happens in emphysema.
Right, that damage is permanent.
Blocking this hyperactive nerve signal is basically the single largest reversible component of their airway narrowing.
It is their absolute lifeline. But the pharmacology gets even more elegant here.
Oh yeah, this is my favorite part of the research.
Because the airways contain more than just M3 receptors. There is a built-in safety mechanism called the M2 autoreceptor.
This was one of the most fascinating conundrums in the sources for me. So the M2 receptors sit on the nerve endings themselves, acting as a negative feedback brake.
Correct.
When acetylcholine starts piling up in the airway, it binds to M2, and the M2 receptor sends a signal back to the vagus nerve saying, okay, we have enough acetylcholine out here, stop releasing it.
It's a perfect feedback loop.
Right. But here's where I get a little confused. If the original drug, ipratropium, is non-selective, meaning it blocks M2 just as aggressively as it blocks M3, aren't we accidentally cutting the brake lines while trying to stop the car?
That is the exact paradox that forced pharmacologists right back into the lab.
Because we're blocking the downstream narrowing effect, sure, but we're actively removing the very mechanism that tells the nerve to stop firing in the first place.
Right. Blocking M2 is completely counterproductive. You want to leave the nervous system's natural brake intact, while simultaneously blocking the gas pedal that's causing the spasms.
So how do you solve that mechanical puzzle?
Well, solving that puzzle is what led to the development of the next generation drug, tiotropium. known by the brand name Spiriva.
Okay, but how does tiotropium solve the brake line problem if it's still binding to these receptors?
It uses a concept called kinetic selectivity.
Kinetic selectivity.
Right. Usually when we talk about a selective drug, we imagine a lock and key. We mean the drug only fits perfectly into one specific receptor lock and simply bounces off another.
Like it only fits M3 and ignores M2?
Exactly, but tiotropium doesn't do that. It actually fits perfectly into both the M2 and M3 locks. The genius is in how long it stays there.
So it's a matter of time and grip strength.
Exactly. Tiotropium binds to both receptors, but it is incredibly slippery on the M2 brake receptor.
So it falls off.
It falls off almost immediately, leaving the negative feedback loop functioning. But when it binds to the M3 receptor, the one causing the deadly narrowing in the sludge, it clamps on like a vice and just refuses to let go.
And the pharmacology data and the sources shows it has a half-life on the M3 receptor of 34.7 hours.
Which is astounding.
Almost 2 full days of gripping that receptor and blocking the spasm.
Clinically, this changed the entire landscape of COPD treatment because ipratropium, the older drug, fell off the receptors pretty quickly, so its effects only lasted maybe 4 to 6 hours.
So patients had to remember to use their inhaler 4 separate times a day.
Which is a massive burden for an elderly patient. But tiotropium's astonishing 34.7-hour grip meant patients only had to take one single dose in the morning, and their airways were protected for a full 24 hours.
It's just an unbelievable chemistry hack.
Truly.
But, looking at the cold, hard evidence from the massive clinical trials, we see a really stark philosophical reality about treating chronic disease.
Oh, absolutely.
Because the chemistry is elegant, the receptor kinetics are perfect.
Yeah.
But what actually happens when we give these advanced inhalers to thousands of human beings over several years?
Well, the clinical trials for these drugs are foundational for anyone studying medicine. Let's look at the PUAT COPD trial from 2011.
Right.
This was a massive head-to-head matchup between tiotropium and a drug called salmeterol.
And salmeterol attacks the plumbing problem from a completely different angle.
Yes. It stimulates the sympathetic pathway, the beta-adrenergic receptors, to force the airways open.
And the PUAT COPD trial proved that tiotropium, which blocks the cholinergic pathway, actually beat salmeterol at preventing COPD exacerbations.
It did, meaning it was vastly superior at stopping the massive flare-ups that require high-dose steroids, aggressive antibiotics, or, emergency trips to the hospital.
That kept people out of the ER.
It did. But then we have to look at the UP-LIFT trial from 2008.
A really big one.
Yeah, this is one of the biggest trials ever conducted in respiratory medicine. Nearly 6,000 COPD patients tracked meticulously for 4 full years. And the results present the ultimate paradox.
Because in the UP-LIFT trial, tiotropium massively improved the patient's quality of life.
Hugely.
They felt significantly better. They could walk up the stairs without stopping to gasp for air. They played with their grandkids. They stayed out of the hospital. But despite all of that, the trial technically failed its primary endpoint.
Yeah, the primary endpoint of the UP-LIFT trial was highly ambitious. The researchers wanted to see if tiotropium could actually slow down the year-over-year decline in lung function.
They measured something called FEV1.
Right. FEV1 is how much air a patient can forcefully exhale in 1 single second. And over time, as COPD destroys the lungs, that number steadily drops.
And tiotropium did not slow that downward slope.
No, okay, too.
The patient's underlying disease continued to progress and destroy lung tissue at the exact same rate as the patients who were given a placebo.
Yeah.
The drug gave them significantly wider airways today, but it completely failed to stop the lungs from deteriorating tomorrow.
Exactly.
So you really have to think about this for a second. If you are the patient, is a drug a failure if it doesn't cure your disease or even stop it from getting worse, but it gives you your daily life back?
It's a profound question, and this trial is taught in medical schools everywhere because it perfectly defines the difference between symptom control and disease modification.
Which is a huge concept.
Yeah. We see this theme constantly in oncology, in cardiology.
Like with statins.
Exactly. A statin drug modifies the actual course of heart disease by stopping plaque buildup in your arteries. It's modifying the disease. But a nitroglycerin pill just temporarily controls the symptom of chest pain by dilating the vessels.
Right. Both are absolutely essential for the patient, but the physician has to know exactly which one they are prescribing. And a similar massive study in the 1990s, the lung health study, showed the exact same thing with the older drug, ipratropium.
Yes, it did.
It helped the symptoms tremendously, but the only intervention that actually changed the downhill slope of the disease and modified the lung destruction was smoking cessation.
Right, quitting smoking.
So tiotropium is world-class symptom control, but it is not a cure.
Not a cure at all.
And speaking of symptom control, the sources clear up another major misconception here. Because these drugs open the airway so effectively in COPD, a lot of people assume they would be the perfect primary rescue inhaler for a severe asthma attack.
Oh, yes.
But that is emphatically false.
It is because, well, COPD and asthma can look incredibly similar to a layperson. They both cause severe wheezing and shortness of breath.
But they are driven by entirely different underlying biology.
Completely different. COPD is heavily driven by that vagal cholinergic tone we've been discussing. Asthma, however, is primarily an allergic inflammatory disease driven by specific immune cells called eosinophils.
So prescribing an anticholinergic as your primary rescue medicine for an acute asthma attack is a recognized clinical misstep.
Yes, you are targeting the wrong pathway entirely. You need an albuterol inhaler, a short-acting beta agonist, to reverse an acute asthma attack.
Now, tiotropium can be a useful add-on therapy for severe asthmatics, right?
Yes, as a maintenance add-on, but it is never the first line of defense for an acute attack.
Okay, so we know the drug works safely to manage COPD symptoms. It keeps people out of the hospital.
Right.
But the story doesn't end smoothly, because in 2011, a massive safety scare almost derailed this entire drug class.
Oh, the JAMA paper.
Yeah, and what's wild is that the panic wasn't even about the tiotropium molecule itself.
No, it wasn't. And this is arguably the most important lesson in respiratory pharmacology regarding drug delivery.
Okay, lay it out for us.
Well, for years, tiotropium was delivered to patients via a device called the HandyHaler.
Which is a dry powder inhaler.
Right. You puncture a capsule inside the device, and you have to take a very hard, fast, deep breath to suck the dry powder into your lungs.
But later on, the manufacturer wanted to improve the experience, so they introduced a new device called the Respimat.
Yes.
And that was a soft mist liquid delivery device.
Yeah.
Same exact drug, tiotropium, just a different physical method of getting it into the airways.
Exactly. But in 2011, a major meta-analysis was published in the Journal of the American Medical Association, JAMA, and it dropped an absolute bomb on the pulmonology world.
What did it find?
The analysis suggested that tiotropium, specifically when delivered via this new Respimat soft mist device, was associated with a statistically significant increased risk of cardiovascular death compared to a placebo.
Heart attacks and death. From an inhaler that was specifically engineered with that positive electrical charge to keep it out of the bloodstream and protect the heart.
You can imagine the absolute terror in the medical community.
Panic.
Regulators immediately hit the brakes and demanded a massive, dedicated safety trial to figure out what was happening.
And that resulting trial was called TioSpear, published in 2013, right?
Yes. It enrolled over 17,000 COPD patients, and they put the old dry powder HandyHaler head-to-head against the new soft mist Respimat.
And thankfully, they found absolutely no significant difference in mortality or cardiovascular risk between the two devices at their approved doses.
Thank goodness. The scare was largely a statistical ghost created by combining smaller, unrelated studies.
But the takeaway here isn't just a sigh of relief that the drug is safe. The crucial takeaway is understanding why the soft mist device caused such a massive discrepancy in the data in the first place.
Yes, and it all comes down to the physics of inhalation. When a patient uses a dry powder inhaler, like the HandyHaler, they have to inhale sharply and violently to pull the powder out.
Right.
And because the particles are moving so fast, a huge percentage of the drug simply crashes into the back of the patient's throat, the oropharynx, and just gets swallowed, never reaching the lungs.
But a soft mist inhaler, like the Respimat, operates completely differently.
Yeah.
It ejects this slow-moving, fine liquid cloud.
Exactly. And because the mist is moving slowly, it navigates past the vocal cords smoothly. The particles don't crash into the throat.
They ride the airflow.
They ride the laminar airflow deep down into the smallest bronchioles and alveoli.
Wow.
And because of this superior physical delivery, the Respimat deposited a vastly higher percentage of the drug directly into the lung tissue compared to the dry powder.
So even though the label on the inhaler might say it's dispensing a similar dose.
The actual effective dose reaching the receptors in the lung was much higher with the soft mist.
And that higher effective dose is what initially skewed the cardiovascular data in the early studies before they recalibrated it.
It proves that the formulation and the physical delivery mechanics of a drug matter just as much as the brilliance of the molecule itself.
That is wild. So what does this all mean for us today? Let's recap this unbelievable journey we've been on.
It's been a long one.
We started in the smoggy streets of the 1800s,
Yeah.
with desperate patients smoking toxic nightshade leaves to get a hit of atropine, literally suffering through hallucinations and racing hearts just to catch a single breath.
Unbelievable to think about.
Then chemistry stepped in. By bolting a permanent positive charge onto the molecule, scientists created a water-soluble compound that stays trapped in the lungs.
The perfect hack.
We looked at the plumbing, how blocking the M3 receptors stops the muscle pipes from squeezing shut and turns off that paralyzing sludge faucet.
Right.
And we saw the sheer genius of tiotropium's kinetic selectivity, clamping onto the bad receptor for 34.7 hours while letting go of the nerve's built-in brake.
Incredible engineering.
And today, millions of people worldwide rely on this precise molecular engineering to manage COPD and get their daily lives back.
It really is a triumph of modern pharmacology.
It is.
But, I want to leave you with one final thought to mull over, connecting back to that RespiMat safety scare we just discussed.
Okay, let's hear it.
We saw how simply changing the physical inhaler device completely altered how the drug deposited in the lungs. It changed the effective dose and temporarily terrified the global medical community.
Yeah, all just from a new device.
Right. It really makes you wonder, over the last century of medical research, how many promising, brilliantly designed molecules have been deemed failures or completely abandoned by science simply because we put them in the wrong delivery device.
Oh, wow. It's wild to think about. We might literally have cures sitting in a dusty archive somewhere, just waiting for the right plumbing to deliver them.
Exactly.
But, at the very least, you can be thankful that today, if you have trouble breathing, you definitely don't have to smoke deadly nightshade to find relief.